Hey, you guys, welcome for topics and tips. As promised, this month we are doing the practice question series. So, on my Tuesdays, my Wednesdays, my Thursday typical videos, we're going to be working out practice questions all month long on each of those days, okay? So, let's get into these questions. But before we do, I always give my disclaimer. So, for those of you who have been watching videos, been taking my courses. Hey, y'all. And for those of y'all who are new to me, welcome. I am Dr. Brittany Weinstock. I am a family nurse practitioner and the founder and CEO of the Nursing Studio. But my disclaimer is always that I do these videos to help nurses and nurse practitioners with board success as well as exam success and in practice. But this is not an end all be all. We know nothing in medicine is absolute. So take it as such and let's go and be successful. All right, let's get into the first question, you guys. The first question states a nurse practitioner completed a fundoscopic exam and noted AV nicking and copper and silver wiring. Based on these findings, what should the nurse practitioner assess and monitor? Is it A, diabetes, B, glaucoma, C, hypertension, or D, cholesterol? Y'all take a moment and tell me what you think in the comments. All right, you guys, as always, I tell you to read the stem of the question first so that you can ensure that you are answering what they're even asking you, right? So the stem states, based on these findings, what should the nurse practitioner assess and monitor? So that means you need to take a step back and see what the findings are, right? So it's a fundoscopic exam. So we're looking at the eye through that ophthalmoscope and seeing AV nicking, copper and silver wiring. So when you're thinking of those, what things may potentially cause those abnormalities on the eye exam? Is it diabetes? Now we know diabetes can cause different vision disturbances, alterations, but is that the best answer? We can hold in and see. B, glaucoma. No, that's not how glaucoma doesn't typically present with that way. Doesn't cause AV nicking nor copper and silver wiring. C, hypertension. Yes, ma'am. Yes, hypertension we know is a common cause for the AV nicking as well as the copper and silver wiring. I do have a video on these topics if you need to go back and refresh your memory on those. But for this one, the best answer for this is C, hypertension. Now, the nurse practitioner should be monitoring those blood pressure levels, making sure that they are better controlled, seeing if we need to treat in a different perspective and monitoring those consistently to get them balanced and to prevent further worsening of the eye, right? And then D, cholesterol was an option, right? But that is more on that arcus senilus eye changes. All right, next question. This question states Ms. Smith has a history of asthma and presents to the office today with complaints of shortness of breath every day. She states that for the past 2 weeks, she has had to use her rescue inhaler daily. Based on these findings, how should the nurse practitioner treat? Is it A, add a low dose inhaled corticosteroid in a LABA? Is it B, add a SABA? C, add a high dose inhaled corticosteroid in a LABA? Or D, add a high dose inhaled corticosteroid? Now take a moment, think through this, and tell me what you got in the comments. All right, reading this stem first says based on these findings, how should the nurse practitioner treat? So we know that a patient has a history of asthma, right? And her symptoms are worsening, or you can say uncontrolled, because she's short of breath every day. And over the past 2 weeks, she's noting that she's having to use her rescue inhaler daily. That's not good. So, what are your next steps? So, you need to think of what stages we're in um, with the asthma stages, the asthma stepwise approach, right? So take a moment and think about which criteria those for the signs and symptoms. Do they have symptoms daily? And I'm just kind of trying to talk you through how to approach these style questions. So first you need to identify what stage, then think about how we treat those stages, and then you can select an answer, right? So what stage would you say that we are in at this point if she's having symptoms daily? And so you should be thinking that she's in the moderate persistent phase, right? Because that's the one that they have daily issues, and it's severe persistent when they have symptoms all throughout the day. So if you're struggling, take a look back at those signs and symptoms of the stepwise approach, etc. And I do have videos on those. But so we're in moderate persistent. So how do we treat the moderate persistent phase? And so would you add a low dose inhaled corticosteroid and a LABA? Yes, that is your answer because one, she says she's using a rescue inhaler daily. One, that shows you two things, that she is symptomatic daily, and two, that she's already on a rescue inhaler, which is what? A SABA. It can be a SAMA also, but most commonly our rescue inhalers are our SABAs, like your albuterol, right? So she's already on the SABA, and you know with the moderate persistent phase, if you're on the SABA, because everybody on the stepwise approach should always have a rescue inhaler. So you have a SABA, but in the moderate persistent, you need to make sure you also have them on a low dose inhaled corticosteroid and a LABA. If it would have told us that she was already on a low dose inhaled corticosteroid and LABA, you can choose to kind of bump up this tier and do a medium dose inhaled corticosteroid with that SABA instead. Okay. But again, moderate persistent, they have those symptoms daily, not all throughout the day, but every day. Typically, they need to be on a SABA, a rescue inhaler, and you also want to include a low dose inhaled corticosteroid and a LABA, a long acting beta agonist, right? All right. Question number 3. A nurse practitioner is assessing Mr. Williams and listening to his heart and lung sounds. She notes in her documentation a systolic murmur located at the apex of the heart. Which murmur listed shows an appropriate diagnosis? Is it A, mitral regurgitation, B, mitral stenosis, C, aortic regurgitation, or D, aortic stenosis? Take a moment and tell me what you think in the comments. All right, read the stem of the question first. So, which murmur listed shows an appropriate diagnosis? All right, so the nurse practitioner says it is a systolic murmur and it's located at the apex of the heart. So, you need to step back and, I tell you when you're reviewing your murmurs, know whether they're systolic versus diastolic. Understand that first. Know their location, know their presentation, and you can always break down these questions, okay? So it already told us it's systolic. So what are your systolic murmurs? So me, there's so many mnemonics. Stick to whichever one works and helps you. But my Brittany's brilliant. I say think sassy systolic because the sassy systolic crew says men really are stupid. So men really being mitral regurgitation, MR, are stupid, AS, aortic stenosis, right? So we know that narrows it down to the answer choices A or D. Next, it says that it's located at the apex of the heart, right? So is it aortic or mitral at the apex of the heart? Mitral, right? Because aortic is at the base of the heart. Aortic is at the second intercostal space at the base of the heart. So anytime you see something at the second intercostal space, if you're auscultating at the second intercostal space or the base of the heart, you're thinking aortic. That's that aortic location, right? And mitral is at the fifth intercostal space at the apex of the heart, right? Again, go check out my videos for better explanation if you need to take a moment and really delve into this a bit more. But this lets you know that at the apex is mitral, right? So your best answer choice is A, mitral regurgitation. Mitral regurg is the systolic murmur and it's located in that mitral region at the apex of the heart. All right. And the last question of today's practice question session states the nurse practitioner is explaining the test results to the nurse practitioner student. She is explaining the type of anemia that should be documented and discussed with the patient. Based on these findings, which anemia should be documented and discussed with the patient? Findings are it's microcytic, hypochromic, there's low ferritin, high total iron binding capacity, and a low iron? Is it A, thalassemia, B, B12 deficiency anemia, C, folate deficiency anemia, or D, iron deficiency anemia? Take a second and tell me what you think in the comments. All right, all right, all right. So, stem of the question first, and it states based on these findings, which anemia should be documented and discussed with the patient. The findings are microcytic, hypochromic, low ferritin, high TIBC, and a low iron. So, what iron do you think of? What deficiency do you think of anemias when you think of this? When I give you those findings, and I'm halfway saying the stuff, but um, if you have anemia, as you know, your patient is going to present the hemoglobin, hematocrit are low, right? So we're in the anemia criteria, and then you need to look a little bit different to be able to determine what type of anemia it is. Now, looking at, as I say, cytic versus chromic, that MCV and MCHC, because that's going to give you those values based off of the labs and how they fall in there. We have microcytic, macrocytic, normalcytic, and we have hypochromic, normalchromic, and hyperchromic, right? So this one says microcytic, hypochromic. And in my 2-1-2 rule, I tell you, in that smaller category, there are two that fall in the category of microcytic and hypochromic. And that's your iron deficiency anemia and your thalassemia. So here you can break this down to know it's either A or D for this answer choice, right? Now, how do they differentiate? So thalassemia, the ferritin and iron levels are going to be normal because that's not what's affected here. But with iron deficiency anemia, it's low, right? Ferritin being your iron stores, and then your iron levels, they're low because you're deficient in iron, right? And your total iron binding capacity is high because it's the opposite. It has a high level of binding capacity because it's not binding to any iron because your iron is low, right? So therefore, the best answer choice here is D, iron deficiency anemia, because your ferritin is low, which is your iron stores. Your iron is low, your iron levels, and your total iron binding capacity is high. D is your answer, IDA, all day, every day. All right. So I hope you found this helpful. As always, please like, comment, and subscribe and share with whomever you may think may find this beneficial as well. But be sure to meet me back here. Bye, y'all.